See, infertility, Simrat, is not a disease, I would say. It's a desire.
What is a premature ovarian insufficiency?
So, if a female's ovaries have stopped working at a hormonal level, at a reproductive level, before the age of 40, we call it as premature ovarian insufficiency.
Is premature ovarian insufficiency reversible?
As far as the fertility is concerned, there is no way to treat a premature ovarian insufficiency in a way that we can reset the clock. No, that can't be done. But yes, that can be treated if the woman or if the couple is coming at the right time to us.
Hello and welcome to Fertility Tales powered by Nova IVF, the podcast that brings hope, insights, and clarity to your fertility journey. I'm your host Simrat, and in today's episode, we delve into a topic that many women are not aware of and isn't often discussed: premature ovarian insufficiency. We are honored to have Dr. Vandana Bhatia with us today. Dr. Bhatia has extensive experience in obstetrics, gynecology, and infertility with over 18 years of experience all over. She believes in helping her patients understand the IVF journey before treatment, enabling couples to make an informed decision. Her expertise includes advances in assisted reproductive techniques and premature ovarian insufficiency. Dr. Vandana, it's a pleasure to have you with us today.
Thank you, Simrat. Thank you for having me over on this podcast, and especially on such an important topic, which, as you rightly said, is very less discussed.
True, doctor. Very true. Let's start at the very beginning. How did you choose medicine and how did you choose infertility as a specialization?
Well, honestly, as far as medicine is concerned, I belong to a family of doctors. So I was left with no choice but to join medical. But then, yes, gynae was my passion because my grandmother was a gynecologist. But infertility as such was not in my domain at all. Honestly speaking, it is all by default that I ended up being an infertility specialist. When I finished my senior residency and training from PGI Chandigarh, we had relocated to Delhi. And because of some health issues and everything, I just wanted to take some break. And one of our common friends suggested that I should meet Dr. Malik for that. And when I happened to meet her and she heard everything about what I was going through, she offered me to join her. And she, at that point of time, was, practicing gynae obs as well as infertility. And she was a name in infertility.
Yeah.
I categorically told her that I don't know anything about infertility. And she said, don't worry, you will learn with time. You've come so far, you will learn with time. And that's when I joined her, and touch wood, there has been no looking back since then. And as I actually joined her and started practicing with her, learning basic and then learning the tricks of infertility, the broader aspects of infertility treatment, I got a little passionate about it. And here I am now.
Helping so many couples.
Only infertility. Yes, it is, because see, infertility, Simrat, is not a disease, I would say. It's a desire.
Rightly said.
And when you come across a person or a couple, I would say, who's going through this, it is a very, very different kind of a journey. It is a very different kind of a thought process as a doctor also. And it is a very different kind of it is a very different level of treatment that you are giving to the couple. It is at an emotional level. It is at a medical level. It is
at a psychological level.
It's a hand-holding, basically. So, and you get to learn from these couples. I get to learn a lot from these couples because they are so they're so strong mentally and emotionally to go through the failures, to bounce back again. It teaches you a lot.
I think the resilience is something that you have to deal with, something that it's a part of the journey.
But to have a resilience where you don't have any physical disability, and to have that resilience where you know you are failing. And whatever's said and done, with females, it becomes very difficult to take that failure. You always feel, the patients, that is what we feel, that the female always feel, I have failed again. And then they bounce back again. We have to learn from them.
That's true. In fact, through this podcast this is something that we're trying to address also, that
Yes.
even there are so many fertility tales, so much hope that people can actually rely on,
Yes.
considering the advancements that have happened in the infertility sector.
Correct.
So wishing everybody who's on this journey more clarity through this.
Definitely. See, science keeps on advancing day in and day out. We have seen science has advanced so much. When actually the treatment for infertility started, there were hardly any options. And now look at the options these couples have.
That's true.
It's actually mind-boggling. And to pick up the options, to pick up the right option for the right patient, for them to be successful in their treatment is something we are all thankful to science for that, definitely.
And that is very important, doctor. Let's start at the very basics of premature ovarian insufficiency. What is a premature ovarian insufficiency? How do you diagnose it, and what are its symptoms? Could you tell us a little bit about it so that the listeners also understand?
Yes. Premature ovarian insufficiency, as the terminology, from the terminology itself, you can pick out that it's premature. So it's not physiological. That means the ovaries of a woman has stopped working, or they have entered into a kind of, they have stopped working the way they should be before a particular age. And when we say premature, we take that age limit as 40. So if a female's ovaries have stopped working at a hormonal level, at a reproductive level, before the age of 40, we call it as premature ovarian insufficiency. Earlier, people used to address it as primary ovarian insufficiency or a premature ovarian failure. But now the correct terminology is premature ovarian insufficiency. That ovaries functions as far as the hormones are concerned, as far as ovulation or other reproductive system is concerned, it is insufficient. The ovaries are insufficient to to perform its functions well, the way it should. And the age criteria is before 40 years of age. Now, how do you diagnose it? Well, if a young woman, say in her 30s or in her 20s, has missed her periods, and she has missed her periods without any cause. Earlier, they were very regular, and she has missed her periods, say, for 3 consecutive months.
Okay.
Or for 4 consecutive months, then she must go and see a doctor. Maybe the cause is not ovarian insufficiency, but the cause may be something different, but she must see her doctor. And then the history itself, taken by a medical specialist, will guide us where we are leading to. What is the cause of her missed period? So that may be the first symptom coming from the female, which may lead us to that diagnosis that she may be a candidate who's going towards a premature ovarian insufficiency. Then, of course, a detailed history has to be taken. The family history has to be taken. Her menstrual history has to be taken. And then finally, the diagnosis from a diagnostic point of view, we need to do certain hormonal tests in the form of FSH, in the form of estradiol levels, to know where exactly do we stand. So basically, for the diagnosis of premature ovarian insufficiency, if a woman has her periods or has missed her periods for more than, say, 4 months consecutively, or her hormones are in that range, which suggest that she is going towards a premature ovarian insufficiency, then we label the patient as that, yes, she is a patient with a diagnosis of premature ovarian insufficiency.
Okay. So, doctor, a patient might have other issues as well. It might not just be premature ovarian insufficiency. So to be able to tell that the person has ovarian insufficiency, what all diagnosis is done? What are the implications?
Rightly said, the female may miss her periods because of other reasons as well.
Yeah.
And especially when a female is in the reproductive age group, the first thing and the first foremost test we do is a pregnancy test.
Correct.
So if pregnancy is ruled out, then we start looking at the other causes. We start looking at the history. Has she gained weight? What is her appearance like? We have to diagnose, because there is a condition with females known as polycystic ovarian disease. We are all well aware of. So in that also, the female can miss her periods. So we have to differentiate between these diseases as well. So the history will guide us. The physical appearance of the patient will guide us. Whether she's she's having excessive hair growth, whether she's obese, what about the acne? What is the history of the menstrual cycle like? Is she having a withdrawal bleed? Is she not having a withdrawal bleed? Whether she was taking medication to bring on her periods earlier on in life also, whether there's a history of any recent weight gain, or of course history of smoking, history of any substance drug abuse, or you can say any stress factors in her life. So all this history has to be taken into account. And then of course the final frontier is the investigations.
Okay, so that's when you're able to rule out PCOD,
Correct.
PCOS, or premature
We have to
ovarian
differentiate,
insufficiency.
definitely, because these are two different these are two different ball games altogether, from a treatment point of view, from a management point of view, everything.
Okay. Doctor, you mentioned stress as one of the factors. Does stress cause premature ovarian insufficiency?
I won't say that stress is per se causing premature ovarian insufficiency, because if you really look at the broader aspect, who doesn't have stress in life today? It's a mad rat race. And every disease, whether it is a gynae disorder or, a medical disorder, diabetes, thyroid, everything somewhere or the others is related to stress. So yes, stress can be one of the factors, but to say that stress only is causing premature ovarian insufficiency, I would not buy that.
Okay. And how often do you diagnose premature ovarian insufficiency in the Indian population? How often do these cases come to the forefront to you? Has it been a recent trend?
Yes.
And the fertility landscape?
Yes, definitely. What the practice that we had earlier, say 15 years back, we would hardly see, or 18 years back maybe, we would hardly see 2-3 cases maybe in 6 months, 2 cases in 6 months of this premature ovarian insufficiency, a girl walking in or a woman walking in with this kind of a history, and and we telling her that your ovaries are now going to stop working. But now the things have drastically changed. I think the population which is covering the as a cause of infertility, premature ovarian insufficiency is becoming more and more now. Maybe because of the awareness, girls are coming out. That is one factor. But apart from that, definitely the premature ovarian insufficiency incidence, even in India, is on an increase. It could be the environmental factors, because the environment 20 years back and now has drastically changed. The lifestyle is taking its toll. The stress, smoking, drug abuse, weight gain, lack of exercise, all these are contributing towards a change in pattern of the menstrual cycles that we are seeing in females now.
That's true. What could be some of the lifestyle changes that you could suggest for somebody who is trying to conceive with premature ovarian insufficiency? Or I would rather put it like, is premature ovarian insufficiency reversible? Is there a way a person who is dealing with this, how can they plan their conception?
Premature ovarian insufficiency, as far as the fertility is concerned, there is no way to treat a premature ovarian insufficiency in a way that we can reset the clock. No, that can't be done. But yes, that can be treated if the woman or if the couple is coming at the right time to us. We have for premature ovarian insufficiency or a premature ovarian failure, what we are bothered about is the lack of ovarian reserve. The low ovarian reserve in a female means the clock is ticking, the follicular pool, the egg pool, as I may put it for a layperson, is depleting. Either there was initially the reserve was less, or because of some factors now, the follicles which were there are getting depleted at a faster rate.
Okay.
So the reserve of this female is less. So if such a female is coming and she is in that phase where the ovarian insufficiency is there, then we have to guide her, and especially if she's looking for an infertility treatment and if she's planning a family, she really has to, we have to be very fast forward with her treatment. We can't be sitting back on it, and definitely a patient with premature ovarian insufficiency, IVF is the treatment of choice. Still, if she falls into that category where we can offer her. And with this, I would like to add that there is a 5 to 8% chance in a patient who has a premature ovarian insufficiency that these patients can still conceive spontaneously.
Oh.
Yes, they can, depending upon their age, if they are at a younger age group. Okay, but if there are 40, say 38, 39, physiologically also the egg reserve and the egg quality has to go down by that age. So at that age group, yes, the chances would be less. But in a younger population, there is a chance of a natural conception also, but they should not be waiting for this miracle to happen. If they know that, they have a premature ovarian, their reserve is low, then, and if they're planning a family, they should quickly, just go for the treatment. And if they want to use their own gametes, own eggs, then the sooner the better.
So there is probably 5 to 8% chance for somebody dealing with this to have a natural conception.
Yes,
also.
Definitely.
Doctor, can you differentiate between premature ovarian insufficiency and early menopause? Is there a similarity here?
No. See, when we call menopause, it is natural. It can be a premature menopause, yes. But when we say premature ovarian insufficiency, the female is still having periods. They may be irregular. The ovaries are functioning, but at a very low level.
So the egg is getting released, but it's not...
It may not be getting released also.
Okay.
It may not be getting released. We may have to give a certain, a kind of, as I said, that if the patient is planning a family, we may have to go take this patient up for an IVF if her age is coming under that purview and if her hormones suggest that yes, we can give it a shot with her own eggs, or otherwise we have to go in for a oocyte donation program with these females. But premature menopause is where there is a total ovarian failure, the ovaries have shut and the patient doesn't have periods at all. So their management would be different, their needs would be different. So it is basically an overlap, I would say, but yes, they are different.
So you're saying that in premature ovarian insufficiency, the woman gets her period. It is...
They may be irregular.
They may be irregular, but the possibility of conception is also there.
Yes, it is there. We can't totally negate it. She can conceive in premature ovarian insufficiency if she's of a younger age group. But in premature menopause, everything has shut down. She's not even having her periods. So these are two different aspects. The management in premature menopause, where there is totally a menopause, everything, we have to offer her donor eggs. Here, with premature ovarian insufficiency, if she falls into that spectrum and she has a wish to conceive with her own child, we can still give it a shot.
Okay. And the fertility treatment for this would be?
IVF.
IVF. A woman has a little bit irregular periods. She could have any other underlying causes.
Correct. We need to know the cause of her irregular cycles.
Yeah. And she could just come to the doctor and one day be like, hey, I think I'm not getting my period. And then suddenly the doctor will tell her that you need a certain diagnosis and it could be premature. So how much time would she actually have to plan her life?
Her pregnancy.
Her pregnancy.
Depending upon what her hormones are, depending on what her ultrasound finding is.
So then do you think egg freezing is also like,
yes,
is that a...
Definitely. If she is a candidate, suppose there is a family history of something, autoimmune disease or something, or we are expecting that, yes, this patient is at a high risk of a premature ovarian insufficiency, then you have to tell her. I'll give you an example. Suppose the patient has been detected with a cancer and she has to undergo a chemotherapy. So before chemotherapy, and these chemotherapeutic agents are very toxic.
Correct.
And they are going to block your ovaries, okay, put a stop to their function. So before it happens, we have to tell that female, okay, before the chemotherapy starts, you can go in for fertility preservation. Even if you are not married, you can freeze your oocytes.
Okay. Doctor, what causes premature ovarian insufficiency? Is it hereditary?
See, premature ovarian insufficiency can be spontaneous or it can be induced. When we say spontaneous, yes, without any reason, a female may be having normal regular cycles, everything going on normally, and one fine day she starts missing her periods. And then after 4 to 5 months, when she sees a doctor, and then after the investigations, after history taking, we feel that, well, she has, she's going towards premature ovarian insufficiency. And now in this case, there is no history of any surgery done. There is no history of any chemotherapy or radiotherapy which has been taken. There is no family history of any kind of premature ovarian failure where her mother or grandmother may have gone through. So there is no positive family history in this case, no autoimmune disease, nothing of that sort. So here we may not be able to know the cause, and we label it as idiopathic. We don't know what the cause is, what has caused this. In few cases, yes, by family history, we can have a judgment, well, that may be heredity. It could be. There are certain syndromes which may lead to, this premature ovarian insufficiency, like Turner syndrome. Normally, a female has 2 X chromosomes. Now, in a female where 1 X chromosome is either missing, or, it has got some kind of a derangement, or it's not functioning properly, something like that, then of course, this female is at a more risk of having premature ovarian insufficiency. Now, the other part is induced. When we say induced, it may be iatrogenic, means it has been induced by some kind of treatment that she has taken. And when we talk about this segment, the first thing is the chemotherapy. Suppose a female who has unfortunately has had any cancer and she requires a chemotherapy for that, then yes, these agents which are given for the cancer treatment can be very detrimental to the ovarian function, and they can lead to a premature ovarian insufficiency later on. So similarly, radiotherapy, well, that also will be what are the doses, what are the agents that we are giving, and what is the age of the patient at that point of time. So these are the concerns which are going to be there. So radiotherapy, chemotherapy, or some patient who's had tuberculosis, abdominal tuberculosis, which has affected the ovaries also, or some patient who has bad endometriosis and she has to undergo a surgery to remove those endometriomas, and with the endometriomas, a reasonable part of the ovaries has also been removed. So naturally, when the ovary has been removed or has been destroyed or has been insulted, that patient is bound to go into a premature ovarian insufficiency.
Okay.
So similarly, there are other disorders like Addison's disease, certain autoimmune disorders, thyroid dysfunctions. So these are the factors which may lead to premature ovarian insufficiency.
Okay.
So these are the causes basically. And when these causes are there, when the female comes to us, we have to kind of come to a conclusion that whether this female has any cause for her premature ovarian insufficiency or probably it's idiopathic. That only we'll come to know from the variety of from the tests that we do, whether it is karyotyping, whether it is an hormonal investigations that we do in the form of FSH or estradiol or thyroid or prolactin levels, and so on and so forth.
So detailed history and thorough investigation is what you can tell gives you the
Yes,
right
the
answer for the
cause.
cause.
Definitely.
Got it, doctor. So, doctor, for somebody who is diagnosed with premature ovarian insufficiency, what can be their way forward?
Somebody who's been diagnosed, the management would depend upon what are the concerns of that patient. Number one, what is the age of that patient when the premature ovarian insufficiency has been diagnosed? And at that point of time, what is she looking at? Is she looking at whether she's married or unmarried? If she's not married, then from a fertility point of view, then we can offer her fertility preservation, okay, before she really goes into a premature ovarian failure totally, or even that chance goes out. So we can offer fertility preservation. She can have her eggs frozen, okay, if she's a high-risk candidate for a premature ovarian insufficiency. And if she is married and she wants to plan a pregnancy, then definitely IVF is an option for her. She can use her own gametes. She can at least try with her own gametes. And if we are lucky enough, she may achieve a pregnancy. And if we feel that there is no reserve, the antral follicle count is not there, or the hormones are such that she should not even try with her own eggs, then of course it is the third-party reproduction, that is the oocyte donation programs which she can enroll into. So this is as far as her fertility is concerned. And if she's not planning a pregnancy and she's married, and we feel that, and her reserve is low, or she's a high risk that she will land up into a premature insufficiency sooner, then she can have her embryos frozen also.
Okay.
So for unmarried females, the option is oocyte egg freezing. For married females who are not planning a pregnancy, the option would be embryo freezing. And for married females who are planning a pregnancy, of course, it is IVF with embryos and with an embryo transfer as soon as possible. So, and other part is that if the pregnancy is not on the cards and she's a candidate who's at risk for this disease, then she has to look into the other aspects of her health also. Because ovarian function is not only related with fertility. There are other functions.
Overall health also.
Overall health issues, as far as the cardiovascular problems are concerned, as far as, your psychological and mental issues, health issues are concerned, then your bone mass is concerned. So these are the issues which have to be dealt with, especially if these females are of a younger age group. So these are the symptoms which are there, which can be in this patient, and they mimic what a female is going to suffer at 50 when there is a natural menopause. So keeping those things in mind, psychological counseling is very important. They can look into so many organizations which deal, and if they come across few people who are having the same issues as they are, it peps you up. That psychological health is very, very important. The family support is very important. Then calcium supplements are very important. Vitamin D3 supplements are important. And as far as your cardiovascular status, because these are the females who are at high risk for these problems later on in life, because they have attained, their ovaries have stopped functioning prematurely. Yes. Okay. So when a natural menopause has to come at 50, 51, they are suffering those kind of symptoms right now because the ovaries. So apart from fertility also, these are the issues which a female should be aware of, should look into, and of course the management therapies have to be there.
Rightly said. And like any other diagnosis, I think an early diagnosis is the key to managing it.
Yes.
Doctor, what would be your advice for couples who are coming to you with this pre-existing condition or have been diagnosed with this condition? What would be your advice to them?
Again, as I said, the couples who are coming, if any couple who's married, because we are seeing such a shift in the spectrum now, that we are really ourselves at a loss as to what is happening. People maybe blame it on environment, blame it on the lifestyle, blame it on too much of cell phone use, or whatever you may call it. We really do not know what is. It is all a mixed bag which is affecting the health issues of the female, especially the fertility issues. And the advice to these couples is, well, if you're looking at an fertility and you think that you are at a high risk of premature ovarian insufficiency, well, a female will never come to know whether she's at a high risk or not. The only advice is that if you have missed your periods for, say, 3 to 4 months consecutively, and you do not find any obvious cause for it, it is very important to go and meet a doctor to pick up, because it is the patient's first symptom which is going to guide. The doctor is not going to go to the patient. The patient has to come. The female has to come. And the best way that she can come early is to be aware of what a menstrual cycle length is like, what she should be expecting, that there out of 12 months, she should be bleeding how many months in a cycle? What should be her cycle length like? If there is any change in the menstrual pattern she's observing, and she's been observing for 3 to 4 months, then it is high time that she should go and meet a doctor. And the couple who have been trying for a pregnancy, especially the females who are 35 years and less, and who have been trying for 1 year and without any other factors, they are not able to achieve a pregnancy, they should be meeting a doctor, an infertility specialist, at least to have the hang of what is going on. And if a female is above 35 years, then we say that after 6 months of trying, she should be meeting a doctor. Because when you say fertility, then we have to find out the cause why she is not conceiving. The cause may be any. And premature ovarian insufficiency is one aspect of the whole box. So to diagnose, and of course, once these patients are diagnosed, then we don't have much time for them. So it is the earlier diagnosis. So I would say the couples who are trying for a pregnancy, if they don't achieve, as I said, if they don't achieve a pregnancy after 1 year of unprotected intercourse, and especially if the female is below 35, she should meet a doctor. If she's above 35 and after 6 months of trying naturally they have not conceived, and there is no other factor, there is no high risk factor as to what they think, they should be meeting the doctor. And if there is any kind of factor that she has been a previous case of, say, endometriosis, or her cycles have been irregular, or she is having periods only after taking the medication, then it is, of course, earlier that she should be meeting the doctor. And for mothers also, I would like to say, if their daughters are having this kind of an issue, they should be open about discussing with the doctor that if these girls are going to have any kind of fertility issues later on in life. So that is very, very important. It is not only for that present thing that they have to be concerned about. They should be concerned about for the future as well. And definitely all the females have to take care, because we keep our health at the back of the thing. Yes. Health issues, lifestyle, psychological health issues, physical health issues, exercise, these all are very, very important whenever you are dealing with a fertility issue.
Got it, doctor. In the end, I would like to ask you some interesting cases that you came across during your span of 18 years of practice.
Lots.
I'm sure.
Not one. I'll just tell you one or two odd. So with this, few years back, I think this is about 2017 or 18, there was a couple, very well-educated couple, who came to us, and she showed me the reports. She had already done the reports, and she showed us the reports, and she was trying for a pregnancy. She had a daughter. They were trying for a second child, and she showed us the reports, and the hormones were over the roof. So the first aspect that we told them was that, and they were not one report, there were 2-3 reports which said the same thing, and we termed them as, and she was having regular cycles. We said that this is primary ovarian insufficiency. So I believe the reports are so bad, that the hormonal reports are so bad, that we will not be able to offer you even trying with your own eggs. And we offered her a donor program. And then she just laughed it off, and she says, "Doctor, why donor? Why not with my own eggs?" I said, "Your hormonal reports are not looking okay, seemingly okay, and it would be a waste of time and a waste of money." So she says, "Doctor, these reports have been there like this. The pattern has been the same for the last 3 years. And I had my daughter on the same reports, and it was a spontaneous conception. So after I had my daughter, when I had conceived my daughter, the doctor told me that it is a miracle. So now I don't want that. I don't want to wait for that miracle, and I want that I should be treated, I should go in for a treatment for my second child as soon as possible." And she refused to go in for an IVF. She never wanted. So we had offered them that we will, you can plan an IVF with your own gametes. You can try if you feel like. And donor option was a big no for them. But then she said no IVF. She never wanted an IVF. She just wanted a spontaneous pregnancy. And we said, "We can't offer you. There is no treatment. We can't reverse it." So this was the female who had a spontaneous conception at such a high level of FSH with irregular cycles, which, as I said, there are 5 to 7%, 8% chance that you can conceive naturally. So these cases do happen, and they are an eye-opener for us. And now for low ovarian reserve, if the patient has a low ovarian reserve, which is different from a premature ovarian insufficiency, there are so many advancements in science that you can rejuvenate the ovaries. There is methodologies like PRP and everything, where you can rejuvenate the ovaries, bring back a little bit of ovarian reserve at a younger age to help these couples, have their own child, own genetic child. So this was just one example of such a case. There are so many examples where these patients come, but definitely it is not that all of them conceive with their own eggs. Few people have to resort to a donor egg program. They try, but then, yes, failures are there.
Thank you, Doctor. Your insights on this topic have been invaluable. I'm sure the listeners who are listening to this will take away so much from it. Thank you so much for
Thank you so much for having me here. Thank you so much.
To our listeners, thank you for tuning in to another enlightening episode of Fertility Tales powered by Nova IVF. We hope today's discussion has provided you with valuable insights into the dynamic world of fertility treatments. For more stories, information, and support, remember to subscribe to our podcast. Until next time, take care and keep moving forward on your path to parenthood. This is Simrat signing off. Stay hopeful, stay informed, and stay connected with us on Fertility Tales. Thanks.